Hi everyone, my name is Russell, and I'll be talking about the effects of speak out on the intelligibility of hypokinetic dysarthria in lay listeners. Let's go. So here's the outline. Pause if you need to. We're going to start with a background and intro. And first, what is Parkinson's disease? Well, Parkinson's is a progressive neurodegenerative disease that impacts dopamine production in the brain. This leads to movement disorders related to a reduced range of motion. Our study will focus on the consequences of Parkinson's on motor speech symptoms and how speech intervention can change the acoustics and perception of speech impairment. The two main behavioral interventions for hypokinetic dysarthria are Lee Silverman voice therapy, or LSVT loud, and Speak Out by the Parkinson Voice Project. Looking at a Speak Out study by Alison Behrman and colleagues, they recruited 40 participants with mild Parkinson's disease and 25 age and sex matched peers. They recorded speech samples from these participants, reading a standard passage and then a monologue. The outcome measures before and after speak out were voice acoustics, but not speech acoustics or speech perception. They found that speak out was effective at increasing mean intensity, which is related to the perception of voice loudness, CPP, which is related to voice quality, for example, how harsh or breathy the sample was, mean FO, which is related to voice pitch, the standard deviation of FO and SPL, which are related to speech stress and quality of life. Only the acoustic measures related to loudness and voice quality improved to target levels, and these measures were all voice acoustics. So, the Behrman study found that the acoustic measures increased, which suggests improvement in voice loudness, voice quality, and voice expressiveness, but they didn't observe post-intervention changes to speech clarity. Just to clarify, voice refers to your voice box, so the source of the sound, but speech refers to your tongue, lips, and mouth, which shapes that speech into specific sounds. So my lab realized that Behrman's team only looked at the acoustics related to voice loudness, voice quality, and voice expressiveness, but not speech clarity. So, in our previous study, we looked specifically at vowels because they have the potential to be early biomarkers for dysarthria even before clinicians can perceive it. And also, vowels reflect the extent of tongue movements. So, vowel space doesn't necessarily talk about the air inside of your oral cavity, but more how far the tongue can move. Specifically, we've manually computed the acoustics called VSA and VAI from the speech samples, VSA being vowel space area, and VAI being vowel articulation index. The bigger they are, the bigger the dispersion or the distinctiveness of the vowels are, and the clearer the speech. And so in our previous study, we found that pre-intervention speech acoustics were reduced compared to the healthy controls. That's the orange compared to the gray. And that's expected because as Parkinson's progresses, we expect speech to be less clear, right? The vowels we expect to be less distinguishable from one another. And then post-intervention speech acoustics, so the blue overshot the healthy controls, and the pre-post changes reached statistical significance with a large effect size. Acoustic studies show that speak out improves intensity, so voice loudness, that's what it's related to, CPP, which is related to voice quality, range, which is related, standard deviation of the intensity and fundamental frequency, which are related to speech, to voice expressiveness, and also vowel acoustics, which are related to speech clarity. These are the combined results of the original Behrman study and our lab's previous study. So, what does this all mean? Computers can hear the post-intervention difference, but can humans really hear the post-speak out difference in speech clarity? So the purpose of our current research is to determine whether listeners can detect a change in speech clarity, and we hypothesize that they can detect a change between pre and post intervention based on what we found in our combined acoustics results in that previous slide. The significance of this study then is that it will address whether the therapeutic gains achieved in the clinic translate into practical, measurable benefits in the most relevant contexts. Those contexts meaning outside of the clinic. Those are the real context. So everyday conversation as judged by ordinary people, not clinicians. The literature tends to focus on the acoustics of voice, but in my opinion, there's not enough research out there that focuses on the perception of speech. So, what did we do to fill these gaps? Well, it's a retrospective study of the same 40 talkers in the Behrman study and the same age and sex matched peers, the healthy controls, HC. They recorded speech samples from a reading passage called Caterpillar. It's about a roller coaster called the Caterpillar. And also, they recorded speech samples from natural conversational speech. So they prompted these talkers to describe in excruciating detail how to make a peanut butter and jelly sandwich. So we're going to, this is my proposal is to recruit 90 lay people to listen and judge these samples. Typically, only three expert listeners are involved, so clinicians, and it's a small sample of listeners. So this proposed study will be a much bigger study. So you guys are all invited to be our participants. The inclusion criteria are that you don't have any experience listening to Parkinson's speech or any dysarthria, and that you're 18 years and older. Typically, in these types of studies, the age range is 18 to 65 years old. Exclusion criteria are, hearing loss or cognition. We'll screen people for these, but and if you don't use English at all, unfortunately, we can't represent these groups in this study, and I'd really like to. But this is what is traditionally done, and we'd like to be consistent with the rest of the literature. The listeners during the study session will listen to these speech samples and then they'll make judgments on a scale called a VAS scale. It's like a Likert scale. So I'm showing a Likert scale here, but also they have kind of a gradient. So maybe that could help explain what a VAS scale is. Yeah, it's like a Likert scale, but more fine-grained. The samples will be judged on the basis of three different dimensions, so three different scales: loudness, clarity, and expressiveness. The outcomes, or sorry, I got ahead of myself there. So after listening and then judging on these three scales, the subsequent samples that they'll listen to will be a random sample that they hadn't heard before. So just talking about the general study design here, there will be three different blocks. There will be the healthy control block, the PD pre and PD post block, and I've shown you guys the randomization. So R represents randomization, so that participants are randomized to the talker blocks here. Um, T represents the speak out intervention applied only to the pre and post PD talker groups. O1 represents the pre-intervention ratings on all three dimensions, and O2 represents the post-intervention ratings after 4 weeks, regardless of whether the talker group received speak out intervention. We plan to use a linear mixed effects model to explain changes in loudness, clarity, and expressiveness as predicted by the interaction between pre and post and reading versus conversation with talker and listener contributing random effects. We're going to measure reliability, comparisons between talker groups, effect size, and the percentages improved and declined. So, what do we expect to observe? We predict that when we look at listener ratings of these perceptual speech features, loudness, clarity, and expressiveness, that the healthy controls will be rated at some level And according to what we've seen before with the Behrman study and their results on intensity, the healthy controls or the pre-intervention PD group would have lower levels of loudness. But after intervention, their loudness levels would be approximately the same as the healthy control group, and the pre-post difference would reach statistical significance. We also predict that the healthy controls would have some level of expressiveness, that the pre-intervention PD group would be judged as less expressive, and that the post-intervention expressiveness ratings would increase but still not match the healthy controls. Again, this is what the original Behrman study suggested using their acoustics data. But then, based on our previous acoustics study, we expect the pre-intervention speech clarity to be reduced and the post-intervention speech clarity to be increased past the healthy controls because we found an overshoot of those vowel acoustics. And we predict that the pre-post change would also be significant. So these results would confirm that vowel acoustics really are correlated to speech clarity, and they would show the effects of speak out intervention on not only loudness and expressiveness, but also speech clarity. Here are our references and acknowledgments. Thank you all so much.